So now for the important event for the Mittal Institute calendar, we have this annual endowed lecture called the Harish C. Mahindra lecture, which was donated to the Mittal Institute a while back by Anand Mahindra. Harish C. Mahindra is a nephew and alumnus of Harvard College and Harvard Business School. And the idea, the instructions to us was to find someone annually who embodies the spirit of progress in India in particular. And I wanted to do two things. One, give you a sense of who has preceded this year's Mahindra speaker. And the purpose of this is to do exactly what I just said, give you a sense, but also give you a sense of the diversity of backgrounds, because we interpret this charge very eclectically. And we always select based on some sort of democratic process of our steering committee, academic steering committee, and so on. So the very first person that I was fortunate enough to invite was Dr. APJ Kalam, the 11th President of India. That was back in 2011. Soon after, I'm not naming them all, but I'm just picking a few. Raghu Rai, eminent photographer and photojournalist. That was a spectacular showing. We put all his photographs up everywhere. Abed Bhai, the chairperson and founder of BRAC, and I basically asked for permission from the Mahindras to interpret, had an effect on India more broadly. It didn't have to be somebody in India. This was somebody in Bangladesh, but I think his work has influenced India a great deal. My good friend and fellow Bangalorean Nanda Nilkani, the co-founder of Infosys and then of the what's now come to be known as Aadhaar, the biometric ID in India, followed by T.M. Krishna, musician and vocalist, Arun Jaitley, Minister of Finance in the government of India at the time, a reform-minded finance minister, if I may say, and most recently, right before the pandemic, so we haven't had someone. We had, yes, of course, you're right. Devki Jain, the economist and writer, talking about feminism. And we had Diana Eck yesterday, and I remember from Devki coming and saying that one of the first people she met when she came to Cambridge 50 years ago was Diana Eck, to bring it full circle. And then we had the celebrated chef, Madhur Jaffrey, was it last year, someone? Last year. So I I'm very pleased to introduce a colleague, Megan Murray, who will then introduce Soumya Swaminathan, our Mahindra speaker. I know Megan only as a fellow traveler in a climate working group that Dan Schrag, the moderator of the previous panel, has convened that meets once in a while for discussing climate-related research issues. Megan is a prominent epidemiologist and infectious disease doctor, physician, has done a lot of seminal work in tuberculosis, and is currently a professor of global health and social medicine and an associate professor of medicine at HMS, where she leads what's called the Global Health Research Corps, which I'll admit to not knowing much about. But Megan's been very kind to say that she would introduce Soumya. So I'll hand the floor to you, Megan. Thank you so much. Yeah.
I can't tell you what a privilege it is for me. I have been a huge fangirl of Dr. Swaminathan for many years. And so the idea that I'm here on the stage with her is really very special for me. Soumya Swaminathan was most recently the WHO's chief scientist, and before that, the Deputy Director General for Programs at WHO. She returned to India last year, where she took over as the chairperson of the MS Swaminathan Research Foundation, and she's been working there ever since. A pediatrician from India and a globally recognized researcher on tuberculosis and HIV, she brings with her 40 years of experience in clinical care and research and has worked throughout her career to translate research into practical interventions. Dr. Swaminathan was Secretary to the Government of India for Health Research and Director General of the Indian Council of Medical Research from 2015 to 2017. In that position, she focused on bringing science and evidence into health policymaking, building research capacity in Indian medical schools, and forging South-to-South partnerships in health science. From 2009 to 2011, she served as the coordinator of the UNICEF, UNDP, World Bank, and WHO Special Program for Research and Training in Tropical Disease in Geneva. She received her academic training in India, the UK, and the US, and has published more than 450 peer-reviewed publications and book chapters. She's a fellow of the US National Academy of Medicine, the Academy of Medical Sciences of the UK, and a fellow of a number of science academies in India. She has received multiple honorary doctorates, including from the Karolinska Institute, the École Polytechnique Fédérale de Lausanne, and the London School of Tropical Medicine and Hygiene. She serves on national and global advisory boards, including the Alliance Biodiversity, the Coalition of Epidemic Preparedness Innovations, the Fund for Innovative New Diagnostics, Population Foundation of India, and many others. She is a governing council member of the Tamil Nadu Climate Change Mission and the chair of ICMR's Scientific Advisory Board. As WHO's inaugural chief scientist, she built the science division with a focus on research, quality assurance of norms and standards, and digital health. She played a key role during the pandemic in coordinating scientific efforts at WHO, as well as setting up COVAX, with a focus on equitable vaccine distribution to low and middle income countries. Please join me in welcoming her.
Can we go over that?
Yeah.
Thank you so much for that introduction, Megan. And also thanks very much for this invitation, Tarun. And it's indeed a great honor and a privilege to be delivering this Mahindra lecture. And we heard the list of very distinguished previous speakers. So indeed, I'm very humbled by this opportunity, and it's lovely to come back and meet a lot of old friends, but also a lot of new friends, and I hope that we can also forge more collaborative work together in the area of climate and health. So what I'm going to do now, it's also a very hard act to follow Dr. Vatwani, I must say. And I think I could see the whole room was transfixed. It was a very emotional 1 hour that I think the journey that you took us on, but it was so important to remind everybody of being empathetic, something that I think we tend to forget in this fast-paced world. And that I think was all the more came out during the pandemic, when not only countries, but everyone, most people were just for themselves. How do you protect yourself? How do you protect your own family? Really not, and maybe that is human nature, but thank you, Dr. Vatwani, for that very inspiring session. So what I wanted to do was, before we enter into a conversation with Megan, I thought I would reflect a little bit on the lessons that I learned. I hope this is not interfering with this. From the pandemic, as a chief scientist of the WHO, where I did get a rather sort of a 30,000-foot view of what was happening around the world, the good, the bad, and the ugly. I was fortunate enough to be in the position of the chief scientist, which had been created only 9 months before we were into the pandemic. So what had happened was that when Dr. Tedros became the Director General in 2017, and he assembled his leadership team, and one of the things he had promised to do was to have both a geographically diverse and a very gender-balanced team. So ended up with a lot of women from different countries in his leadership team, and it was wonderful to be able to work with all of them. But he also wanted to go into a transformation of the WHO because he felt that it was a 75-year-old organization and it really needed to be reset to face the challenges of the 21st century. And while this process took a long time and it was often quite painful, one of the key things that came out, which everyone agreed on, was that there needs to be a much more explicit focus on science. Considering that WHO is a normative agency, is a science-based agency, the fact that there wasn't a science division or a chief scientist, everyone felt was probably a gap. And so that's March 2019 was when I moved from being Deputy Director General, which was more administrative, more managerial, to the position of chief scientist. And I was given basically a clean sheet of white paper to imagine what a science division should do, etc. And this was going along fairly well until December of 2020, of course, when we started getting the first few reports just around Christmas, just before Christmas. So when I remember coming back from a brief holiday in Chennai, back to Geneva on the 4th or 5th of January, and seeing the emergency department going into huddles every morning. And I was wondering what was going on. So I sort of just used to walk into these meetings to find out what was happening in China, in Wuhan at that time. Of course, there was no script for what a chief scientist should do during a pandemic, whereas the emergency division did have a script for how you activate things and what should be put into motion, etc. So I started thinking, what can I do? What can the science division do to support, the WHO and support, of course, all the member states, the countries, to start addressing this huge, big unknown threat that had emerged. And of course, we also didn't know very much in those first few days. And one of the first things we did was to convene scientists from around the world. This was February 10th and 11th. And, well, there were no travel bans at that time. So actually 400 people and all the world's media actually descended on Geneva. And we had this meeting. It was very interdisciplinary and basically came out with a research roadmap. And at that time, of course, a lot was unknown. And so we had a list of research priorities. We formed a lot of working groups, which then expanded and expanded. So we had hundreds of working groups of scientists. And that was also the day, February 11th, when the name of COVID-19 as well as the name of the virus, SARS-CoV-2, were both announced. And again, those were based on principles, and working groups had been working on that. And it was fairly political already by then. And various people were calling and saying, you can't name it this and you mustn't name it that, and so on. But anyway, the principle of naming the disease is that it should be non-stigmatizing, and it shouldn't target a particular person, a name of a country or a city, or even a location. So, and it should sort of describe what the disease is. So those are the principles based on which the name was decided. But I think that that initial meeting, which really galvanized the scientific sort of attention onto all of the unknowns of that pandemic. And the only thing that we knew at that time actually were reports coming out of China, out of Wuhan. And I must say that the doctors and the scientists who were working there were publishing fairly rapidly in real time what they were seeing. And of course, they couldn't travel to Geneva, so we had them online. Remember, these were the very early days of the pandemic. It was very unusual to have people connected online, and we struggled a bit with the technology, but we did eventually have people who couldn't travel were online. So I think for me, from then on, the first and the big and the lasting lesson is that the solutions all came out of science eventually. And whether it was the genomic technologies for surveillance and the kind of variants that we today just talk about very casually, but at the beginning it wasn't a given that the world would be able to track in real time how COVID was mutating and changing, and that we would see these waves of different variants coming, and each one a little bit different, and very quickly scientists having to study the new variant to find out which mutation was causing what property to change, were the vaccine still going to be effective, were the clinical profile going to be different. So starting from that, of course, the big question of how did this virus actually, where did it come from? How did it jump from an animal? How did it travel? Presumably from a bat to an intermediate host to the human being. That question has still not been answered. To what drugs would work. And at the beginning, if you remember, there was a lot of excitement about a lot of drugs that we're already using for other things like hydroxychloroquine or antivirals that are used for other diseases because of some small lab experiments that showed that maybe they were effective. And of course, there was so much desperation to treat. But it was very important to do the clinical trials because otherwise we were all flying blind. And so again, we saw that there were a huge number of trials that started around the world, but most of them were not designed to answer the public health questions of, does it reduce mortality? Does it, really reduce the severity of the disease? Many of them were looking at the reduction in hospitalization duration, for example. So again, the WHO launched the Solidarity Trial, and we named it the Solidarity Trial because by then the WHO had already started talking about why solidarity would be needed to combat the pandemic. And this trial eventually ended up in over 50 countries and enrolled over 20,000 patients, all done online, and answered fairly rapidly in the first few months the questions of whether certain drugs worked or did not. Unfortunately, all the drugs we initially tested were shown not to be effective, but I think it was just as important to find that out so that unnecessary treatments of people could be stopped. Then, of course, there were things like the transmission itself, which again became a very contentious issue. Was it transmitted only by droplets or was it airborne? And a lot of research that went into rapid diagnostic tests, and of course the vaccines. And again, what we did for vaccines was very early on, again, March, April of 2020, we defined what are called the target product profiles, so that everyone around the world knew exactly what the benchmarks would be for a new vaccine to be developed. And at that time, we were going by experience with flu, where, as you know, the vaccines are not very highly effective. They're maybe in the range of 40 to 60% efficacy. So we had thought a COVID vaccine with that efficacy would be acceptable, better than nothing, and of course with a safety profile. And the good thing was that all the regulators, starting from the FDA, the EMA, and most of the regulators around the world immediately aligned themselves with the benchmarks. And this was very different from what usually happens. So from the beginning, the companies knew, the manufacturers knew what targets they had to meet, and they also knew that if they met those targets, that they would get approval from regulators around the world. Now, one of the other things that we saw, of course, was a huge explosion in information. So in the beginning, I remember it was a couple of papers every day, mostly from China, and we sometimes had to translate from Chinese. But then very quickly, this number grew into dozens and then into hundreds of papers every day. It's estimated that 1.5 million publications came out in 2020. It was a huge uptick from the previous. And so a challenge was to be able to scan all of that information and to cull out the important messages that we were getting out of the publication so that we could take that into our guidelines, into our recommendations. So there was a lot of, initially it was manual, but then we realized it was going to be difficult. So we also set up mechanisms to do this more effectively and had something called the living guidelines, which meant that we were constantly updating as new clinical trials came out. We were updating the systematic reviews and then updating the guidelines, because countries around the world were mostly waiting to see what WHO recommended before they would put it into their guidelines. So, of course, what we've seen during the course of the pandemic is a huge increase in innovation and in scientific advances, of course, built on work that had already been done. And so I think what is really important is that investments in science, investment in scientific institutions, and in human capacities actually really paid off. And the countries that had put in a lot of funding in the past, for example, the mRNA platforms, didn't just come out of the blue. People had been working on them for at least 30 years. And there were several other vaccines in phase 1 trial for other pathogens. And this is why very quickly several groups were able to produce these mRNA vaccines really in record time. But that would not have happened if the previous investments had not happened. So I think we know so much more now about immunology, about virology, and it's probably the single most studied pathogen and disease in all of history. So this is, I think, a very good thing. And it also, I think, enthused a lot of people and hopefully more young people also to get into science. It also, I think, brought science into the living rooms of ordinary citizens, because you were reading in the newspaper and watching on television every day, and terms like variants, terms like clinical trials, terms like efficacy, all of these actually became just normal conversational vocabulary. So I hope that we don't forget this lesson, and that investments in science, particularly from countries which haven't invested that much in R&D. Again, one of the things we saw was that there was a lot of inequities or variabilities in where and how science was being conducted. And it's not surprising when you analyze all the billions of dollars that was spent by the research agencies around the world, that more than 95% of that money was spent in high and upper middle income countries. And if you when we looked at Africa, for example, we could see barely, very little happening there in terms of research or clinical trials, except, for South Africa, perhaps with the exception of one or two countries, there was a huge gap in data. In fact, at the beginning of 2020, there were only 2 labs in Africa that could do a PCR test. One was in South Africa, the other was in Senegal. And so you can imagine that very quickly, of course, there had to be training and putting in place equipment, so that by the end of February, there were about 25 labs, I think, that could do it. But still, you can imagine for a whole continent. And this is why there was so much underdiagnosis or lack of COVID diagnosis, and people thought that Africa was spared, that it was not affected. But actually, the reality was that they were affected, but there was just no testing. And so there was no way of knowing, and neither was there cause of death determination. So it was only through postmortem studies, but also through serological surveys, that one later found out that almost everyone had been exposed to COVID, just like in everywhere else in the world. The one difference, of course, is that the median age is very low in Africa. It's only about 18 or 19, and therefore the severe disease, which you mainly see in the older, which we saw in the older groups, there were less of older people. But so this also tells us that countries which don't have systems in place to collect data on deaths, for example, it's very hard really to find out what is actually going on. But we can talk more about that later. So to address the issues of all these variabilities, inequities that we saw, there were many things actually that we put in place starting in 2021 and then going on, and many of those are now progressing. One of them was the clinical trials, that clinical trials really need to be done more equitably, and we brought all the funders of research together to say, how do you, next time around when there is a global emergency, can we have a different way of doing research so that it's more representative, and that you're not only collecting data from some parts of the world. On the mRNA technology, we tried very hard to work with the companies, the 2, Moderna and Pfizer, that had successful mRNA vaccines, to get them to share their technology with companies in other parts of the world that could have quickly ramped up the manufacturing. But we were unsuccessful. And so, again, I remember sitting, it was early 2021, and we were having one of our, as usual, a Zoom call was happening. People were discussing at that time the issue of the lack of vaccines going to low-income countries was really becoming very acute. High-income countries, as you remember, had started vaccinating, starting from December of 2020 onwards. And COVAX, that we'd set up to essentially address this problem that we had anticipated, was not getting the supplies that it needed in order to distribute to the low-income countries. So there were no supplies coming from any of the manufacturers that had already committed their doses to the countries that had paid up in advance. And so they were all at the front of the queue. COVAX had been pushed to the back, and also the Serum Institute of India that was expected to deliver a large number of doses to COVAX, they had to also divert their supplies, of course, to vaccinate people in India who were facing the Delta wave. And so for about 8 months of 2021, we had only a trickle of vaccines coming in. And it was a very frustrating experience. And because we had heads of state, health ministers calling every day from Africa to say, when are you going to send us? And they were only expecting a few million doses just to protect their healthcare workers and their elderly population. But those were not forthcoming. And I think that really resulted in a lot of angst and a loss of trust and a polarization between groups of countries that were well endowed and those that were waiting for a long time. So, of course, it was very frustrating, but what we did do in response was set up the mRNA technology transfer program. And this was directly in response to the refusal of the big pharma companies that had the technology to not share. We said, okay, we can do it in a different way. And that's a more democratic way of just using scientists from around the world who are perfectly capable of doing the same thing, just that it would take more time. And so that's exactly what happened. We set up all through a process of call for applications, and there was a technical review, etc. But the hub was established in Cape Town at a small biotech company called Afrigen. And then there were 16 other spokes that were selected around the world, all based in countries that had some expertise or in some cases no expertise, in order to work on mRNA. Initially, the focus was on COVID, but very quickly it was clear that we didn't need another COVID vaccine, which was going to take some time to develop. So the focus then is on what are the other diseases for which mRNA platform can be used. And it turns out that it's one of the most promising new discoveries or platforms that not only can you develop vaccines for infectious diseases, but you can probably do a lot of other things with mRNA, including monoclonal antibodies, targeted treatments for cancer, and for many other autoimmune and other non-communicable diseases. So having this very vibrant network now around the world of scientists who are working not on the principle of profits, but really for public good. And everything that would be developed through this network, it would have a very transparent process of technology sharing, what we call multilateral technology sharing, unlike voluntary licensing that was done during the pandemic. So the voluntary licensing that's done by private companies one-to-one, and it's a deal between two companies, and there's no transparency there at all. And it again depends on the company whether they voluntarily share their technology or not. Whereas in this case, if you're part of this network, then you agree to certain terms and conditions. So we engaged a lot with many partners actually in trying to advocate for a new model of R&D that would firstly not focus on the market or on profits, but really on public good. Secondly, create a system where instead of a pandemic response, you really started focusing more on outbreak response. Because I think what you can see now is that despite the fact that we've had clinical trials for Ebola, for example, that were again managed by the WHO. And this was not the 14-15 outbreak, but the later ones in DRC in 18 and 19. We have now two therapeutics, monoclonal antibodies. Both belong to US biotech companies that have been licensed by the FDA with a priority voucher that's been given to them. So the two companies have benefited, but people in DRC still don't have access to those monoclonal antibodies. Similarly, Mpox, which of course people in Africa have been getting and dying of Mpox for many years, but it was completely under the radar till, of course, it started spreading in among the gay population in the US and Western Europe, where there was huge flurry of activity, investments, etc. And now there are Mpox vaccines that have been stockpiled, but again, none that are really going into DRC or Nigeria, which are the two countries where actually in DRC, children are the ones affected with Mpox. So it's a different epidemiology there. So I think the story of this unequal sharing of the drugs, or it goes back a long time. We remember the days of the HIV epidemic, when it was believed that Africans, could not take these drugs, or that they wouldn't be able to understand how to take these drugs. And the fact that, of course, the Indian generic companies led by Cipla and Yusuf Hamid actually came to the rescue and enabled millions of people to have access to those life-saving drugs. So what I'm trying to say is that to hope that the situation is going to change in the future, I think we have to continue to hope. But the fact that the pandemic treaty negotiations that are currently going on in Geneva, that are supposed to address some of these issues that came up during the pandemic, and try and fix it so that the next time around we're not back to facing the same issues, is stuck. And it's stuck over these a few issues of sharing of data and information, and sharing of the countermeasures, the drugs and the vaccines. So, and there are, we'll have to see what comes out. The countries have only a few days left now to agree on the terms and conditions, but it's not looking like everyone is on the same page in terms of sharing of intellectual property, knowledge, etc. So even when it's a question of life-saving technologies, you can see that saving lives doesn't always seem to be the top priority for everyone. So I think this is where we have to really think about how science is important. Science will provide the solutions, but if it's not going to be accessible to people who need it, then there's something broken in the system that needs to be fixed. There are many efforts, and I think one of the things is, of course, the developing countries, emerging economies, they need to step up, both in terms of investment, but also in showing that a new model of R&D, where you're building in equity from the very beginning, particularly if it's funded through taxpayer money or through philanthropic funds, and the mRNA technology was largely developed with investments from the NIH. So was developed using taxpayer money, but there are no conditions, that go with licensing that IP to a company. So that's really the issue, which needs to be addressed. So moving on to other lessons, I think is for us to be prepared for the next disease X or pathogen X. And I think what had happened was that from the WHO perspective, after the 2014-15 Ebola outbreak, WHO was criticized a lot for not having responded in the proper way. But also, I think the research opportunity was missed, even though to such a large outbreak, 11,000 people died from Ebola, but the clinical trials could not be coordinated, and it was only at the very end that the vaccine trial was properly done over there. So the R&D blueprint for epidemics was initiated, and that gave us a head start because there was already a framework for how you would go about research during an outbreak or an epidemic, and there was already a column for the pathogen X. So that work is now continued. It's identifying now the top viral families that can cause disease in humans. So there are at least 26 or 27 viral families that can, even though most of the focus in the past has been on influenza, now on coronaviruses, there are many other families of viruses that we need to be aware of and that we need to start research on. And so I think that work will be published very soon with a prototype pathogen in each of those families so that scientists could actually prepare a prototype vaccine, maybe keep it in storage so that when the next outbreak, and it is a question of when, not if, there will be another such event, then the goal is that in 100 days, you should be able to develop a vaccine, and of course also the diagnostics and drugs. So it took us 311 days, I think, 315 days, something like that, for COVID. And the goal is to bring that down to 100. And that can happen only if there's prior preparation, but also a coordinated global effort to both reduce the time taken for clinical trials. So you have sites ready to go, you have the ethics approvals, you have the regulatory agencies all coming on board very quickly. You have the manufacturing capacity, which also needs to be fairly spread around the world, not just located in a few countries. If all of that happens, and if there's a framework for sharing of the vaccines and the drugs, then we should be in much better shape next time. The other big lesson, of course, is that investments in public health are extremely important. And these are often the ones that get neglected by governments, because it's much easier to invest, in a big hospital, something very visible, something that the public can see, that politicians can take credit for. But investing in preventive health, investing in surveillance, investing in capacity of workers on the ground, and basically putting in place, public health measures like good water, clean water, sanitation, air quality, etc. Those are all things which are invisible generally to people. It keeps them healthy, but it requires sustained investment. And that is something that many countries have not done. And we could see during the pandemic that even in high-income countries, those which had dismantled their public health systems or underinvested were doing much worse, because it was believed by many countries that technology could solve the problems, that you just created a few apps and that everything would be fine. But that very quickly proved not to be the case, because without the people who understand what to do, no amount of technology is going to help. Of course, technology is a huge help, and it can be used as a support for the healthcare workers and for the public, but cannot replace people. So I think building a public health cadre, and this is something in India as well, that was the National Health Policy of 2017 talked about how every state, and of course every state in India is like a country in Europe, every state must have a public health cadre, that we have to build resilience in the system, that we should have community health workers who are well trained and well paid, and majority of them are women, that we have to invest more in primary healthcare rather than in tertiary. And in logistics, supply chains, we saw what happened with the shortages of oxygen. In fact, it was very telling that it was during the pandemic that the focus on oxygen, which is a life-saving product, actually came out into the public eye. I mean, there are many, many places where health facilities never had oxygen, and people would routinely die because they did not have access to oxygen, but it never made the news. But during the pandemic, this was in the headlines everywhere. And so at least, hopefully, the oxygen situation has improved. But the fact is that, even last year, the WHO did a survey, 50% of health facilities in the world don't have electricity and running water. And these are likely the places that don't have any oxygen either. So you can imagine the quality of care that's being provided. So that's where the investments are needed, and that's where you can save lives if you make those investments. You also need to invest, of course, in the clinical trial infrastructure and in research. And we also need capacity to do research on what are called the non-pharmaceutical interventions or public health measures. For example, lockdowns or closure of schools. We know now that in some countries these worked well, the lockdowns, because people had access to a good house, they could get their food, the government was supporting them, and businesses that had shut down, but this was not happening. So if you look at the economic impact, there's a huge difference again between high-income countries and the people there, and the lower and lower middle-income countries, where there wasn't that much of government support possible. And so people, individuals and families really took a hit and have still not recovered. So again, so what is the right approach for one country may not be the right approach for another country. And this is where you need public health professionals to be advising the government, and you need interdisciplinary, multidisciplinary teams. And I think we were talking about Richard earlier on. need ethicists. And I think there was maybe one country or two in the world that actually had an ethicist on their high-level government bodies that were advising policies. So I think lesson for the future is you need civil society and people from many disciplines to be there when these decisions are being made. Then I just wanted to mention about the whole issue of the infodemic and the issue of trust and how that played a very big role as well. And this, I think, came as a surprise, I think, to many of us scientists who think, as a scientist, you read the literature, you look at the evidence base, you're of course constantly reviewing in your mind, and you change your mind when new evidence comes out and so on. But that was not how the public was responding. And again, we saw very early in the pandemic that misinformation and more disconcertingly, disinformation, that was information purposely being put out, wrong information to confuse people, had started. And long before there was a COVID vaccine, the anti-vaxxers already had started their propaganda about how these vaccines were going to harm and how all the conspiracy theories had started coming out. So this was something that was, I think, not fully expected by any public health department or agency or the WHO. But I think for the future, we certainly need to anticipate, because I think with the kind of social media that everyone uses today, it's very easy for things to spread very quickly around the world, and bad news always spread faster than good news. I remember speaking to someone from a small West African French-speaking country, and asking her, and this was well into, I think, early 2022, and she told me that only 3% of her country's population was vaccinated. And this was after, supplies had become available. And when I asked why, she said, well, no one trusts the government. And so they get all their information from WhatsApp. And therefore, the only things that are spreading in WhatsApp are, all of these negative stories about vaccines and the fact that the vaccines going to Africa were rejects, from other countries and so on. And so there was absolutely no trust. And so it can have very serious effects on health. So it's not just inconvenient, but it can actually become a very big barrier for public health efforts in the future. So I think the whole science of what is called infodemiology, how to handle the infodemic, is something that people will have to take seriously. We know that there's a lot of misinformation, disinformation going on about lots of other things, including politics. But when it happens in health, and we know in this country as well, that vaccination rates were far lower than what they could have been, considering the availability of vaccines. There was so much, and it was being freely given to people, and yet a significant proportion of people here did not want to take the vaccine for whatever reason. And it was very politicized and very polarizing as well. So luckily, in many low-income countries, this did not happen, at least in India. There were some pockets of vaccine hesitancy, but these were overcome by the public health officials. And so I think one of the success stories was the Indian COVID vaccination program. And it was actually amazing to see such a huge population get vaccines so smoothly with a digital vaccination certificate, all happening very, very quickly. There were other things which, big gaps, but the vaccination program was excellent. We saw that existing vulnerabilities and inequalities in society were exacerbated. So in high-income countries, we saw that racial and ethnic minorities fared much worse in terms of the infection and death rates in particular. And in India, we saw that because of the high underlying burden of non-communicable diseases, very high rates of hypertension and diabetes, even among young people, there were a lot of relatively young people in their 40s and 50s who got very sick and who died, unfortunately, during the Delta wave. So again, it tells us that we can't separate infectious diseases and non-communicable diseases or nutrition or other determinants, they all at some point interact. And of course, what is worrying is the fact that we know from many studies that COVID has increased the risk of all of these diseases, cardiovascular diseases, stroke, diabetes, and so on. And we still don't know exactly how this happens and the mechanisms, both for post-COVID, there are many hypotheses, but also for this kind of longer-term impacts, probably through setting up inflammatory pathways. So there's a lot to learn still about the long-term effects of this virus. But it is one of the things I realized was that we haven't paid much attention to the determinants of health. So during the pandemic, of course, the focus was all on care, on clinical management, on epidemiology, taking care of people who were sick, etc. But we have known for a long time that the drivers of poor health are the social, the political, the economic, and now also the commercial determinants. And if we don't address those, then no amount of building health centers and hospitals is going to make the population healthy. In fact, about 70 to 80% of our health actually comes from outside the healthcare system. It's the food that we eat. Are we getting a nutritious diet? Are we breathing clean air? Do we have access to sanitation, clean water? These are the housing, etc. And so if you look at global risks to health today, the top ones actually are around pollution, indoor and outdoor air pollution, and poor diets. And there's a poster just outside here as part of the Seva exhibition that has a table on the cost of a healthy meal and the fact that over 70% of people in many developing countries cannot afford to eat what would be called a nutritious meal for the day. So this is a very huge issue, of course, and then we know poverty, everything got worse after the pandemic. And so we need to really address and invest in these sectors as well. So when we're talking about investing in health, it's not just the budget that goes to the Ministry of Health, but what part of the budgets that go to the other ministries. And I think climate change is very similar because it impacts our health in so many different ways, directly and indirectly, that we need to start addressing, go upstream a little bit. And it's like the story about these two people who were standing by a river, and they see, that bodies are floating down the river, and the guy who's downstream actually is jumping in and saving these people who would otherwise drown. But then the other person actually goes upstream to say, let me go find out why are all these people falling into the river suddenly. We need to stop it over there rather than keep trying to save people who are drowning. So it's a similar, I think, shift that we have to make. Even if I have access to the best hospitals and doctors in the world, if I'm breathing polluted air all the time, then there's nothing that the doctors can do from making me get sick. So I think that's another lesson. And the fact, of course, that what we're doing to our environment, the loss of forests, loss of biodiversity, the growing urbanization, all of that is only making it more likely. And of course, the illegal trade in wildlife is all making it even more likely that we're encouraging the next zoonotic disease to happen, encouraging the viruses to jump species. So again, looking at taking a One Health approach, perhaps as some people call it, or paying attention to our environment is also equally important. And so finally, I'll just stop with perhaps a word on the use of digital tools and technologies. And we've already had good sessions this morning and we all saw the proliferation of the use of digital technologies. A lot of them really helped, but a lot of them were not very helpful as well. And we talk a lot about AI, but the point is, I think that just like any other technology that we introduce, we also need to test these digital technologies and assess their impact on health outcomes. Not believe that every new technology is necessarily going to be helpful, but what's the context, what's the relevance, and the whole point should be to try and improve health outcomes, improve the way that health workers can either do their work or improve the benefit for people who are accessing health services. And so we need to innovate. We need to be much more, using technology to solve a particular problem, not for the sake of using technology, and involving the communities because of the ethical issues around the use of some of these technologies. We did a lot of work at the WHO on the ethics of, for example, the contact tracing apps and the way that they could be misused. Ethics around mandatory vaccinations, ethics around human challenge studies, and there's a whole body of work on the regulatory frameworks and ethics of artificial intelligence applications in health. We did one also for gene editing. So I think more and more we need to think about the ethics and also who's involved. And the more participatory it is, the more people can get involved and have their say and know what is happening with these technologies, what sort of information that they're giving up, and it should be voluntary. Then I think that there is a lot of scope, particularly I think in developing countries, to use technology to actually improve health outcomes. So perhaps with that, I'll stop and invite Megan to.
Both wired up, so people can hear us? Yeah. Good. Thank you. That was really a sweeping overview of the COVID situation. You and I both worked in tuberculosis, and I think you probably spent many years working in tuberculosis before COVID. And I have to say, during the COVID epidemic, and subsequently, I keep wondering. So TB, for those who don't know, has reclaimed its dubious position as the single infectious disease that kills the most people since COVID. Was in that position for many years, and then was eclipsed briefly by COVID, and now it's back in its role. And what's kind of amazing about it is that we've seen, I think you said 315 days to a vaccine for COVID. When HIV happened, it took longer, but it happened, and within a decade, we had effective drugs that could be delivered to millions of people. So what is it about TB that has made it so difficult to take on in the same way? Why haven't we been able to bring the same kind of scientific and financial resources to this disease that is so devastating?
So I often ask myself the same question, and I don't know if I know the answer, except that one of the reasons could be that TB is a disease of the poor, whereas HIV did impact high-income countries as well. And so some of the examples I gave earlier of the investments in Ebola and monkeypox happened because there was a threat to high-income countries, whereas TB is not really, that even though it's an airborne disease, it's more or less controlled. So that could be one reason, I think, that it affects the poorest of the poor, but also because I think it's been around for such a long time that people have just got used to the fact, and that I must say many people don't know that TB kills so many people. If you just ask someone, even educated people, how many people do you think TB kills? In India, it kills about 1,000 people every day. But nobody knows that. It's never in the news.
Yeah, it's kind of amazing. When I travel to the countries I work in, I'll often meet, people on the airplane or in the hotels, and they'll ask me what I do, and they'll say, "Oh, do we have TB in this country?" It's yes, you do. So it's one of those diseases that is invisible in some ways, and I think it gets back to a huge point you're making, which is that we have technologies, and wealthy countries develop them, and in many cases own them and then distribute them, and they're not incentivized to distribute TB drugs or develop new diagnostics. I mean, it's certainly doable.
It's doable.
So what would you, having been in that WHO world where, they do have some impact on the research agenda. I mean,
Yes.
probably not as much as we'd like them to,
Yeah.
but any suggestions for how to bring these diseases of poverty really onto the mainstream?
Well, I think the WHO helps in many ways. I mean, they do the technical work, of course, again, for TB, there's a target product profile, there's a roadmap, all of that. And very recently, I think Dr. Tedros at Davos this year announced a TB vaccine accelerator, where he's brought, some big philanthropists together and some other groups and said, let's try and accelerate. But it still hasn't, there's no urgency really that I can see around doing that. There are some efforts, and of course it's good to see that there are a few more vaccine candidates now going through trials, but I think they could happen much. And I was hoping that the G20 group of countries would take up TB, and perhaps I've been advocating and saying the best way for pandemic preparedness is, why don't we tackle TB? It's also an airborne disease. Let's work together and set a target, let's do a vaccine for TB in the next 5 years or whatever. That would be a good way to show that, you can work together and get things done, even if we know it's difficult, right, in terms of its immune response to develop the vaccine. But
it's a kind of an intransigent organism. I mean, probably harder to deal with than some others, but it certainly isn't impossible. And we've seen these amazing breakthroughs in other areas. So it's quite depressing in a way.
It is.
So let me switch to a different topic. One of the things I've really admired about you is that you have emerged as a major leader in global health as a woman. We know that about 80% or maybe more of healthcare providers throughout the world are women, but that women play a relatively small role in global health leadership. And we can come up with all sorts of reasons for matriarchal, the history, but things aren't changing as fast as I would have expected or liked. And I'm just wondering what, having been in that position, you mentioned Dr. Tedros's push to put women in positions of leadership at WHO, but there's many organizations that haven't done that, and I feel like we might be at the verge of a backlash that sort of says, well, maybe we'll just go back to the way things were. Well, can you give us some advice on how to keep this momentum going?
Yes, and it is in global health, but it's in many other fields as well. So the good thing, of course, now is at least, we're tracking the data. So the global health, the 50-50 report that comes out every year or every 2 years is tracking. And there's some marginal improvements happening in terms of global health leadership, in terms of the gender balance, but it's still very much male dominated. And if you look at people from developing countries, then of course it's even worse. I think 1% of women on global health boards were 1% of people were women from low-income countries. So that's again a double disadvantage, if you're a woman and if you're from a low-income country. So I think we need role models. So the first thing is to have the data and to be able to track it. You of course need the political commitment. So one of the things that's tracked is how many women leaders come to the World Health Assembly or even to COP. And again, the statistics are very depressing. So very few leaders of country delegations at the climate negotiations are women. And we know that women will bring such a different perspective to the whole climate justice conversation, I think, because it would have experienced a lot of things that men may not have. And then I think is building leadership skills and capacities. I feel the younger generation today is much more able to, is less perhaps, cowed down or defensive. But there are now some programs to take mid-career women, both in science and in health, and give them those skills and give them the tools and also help them, with mentorship and developing a peer support group for them, so that one of the things I think that's factually been proven is that if a man and a woman have the same qualifications and experience, a man is much more likely to put himself forward for a job than a woman. Yeah. And I know this for a fact because it's happened to me as well. There have been things I've seen and I've said, I'm not qualified for this. And if someone hadn't said to me at that point, of course you are, you must apply for this job, I would never have even applied. Whereas a man in my position would certainly have gone ahead and applied. So I think there's that. And then there are all the policies that governments make that can help support women to stay, because very often you end up seeing women take a career break. I think during COVID, we saw many women scientists actually had to take a step back because they had to take care of children and so on. And men's career continued to progress. So the Scandinavian countries, I think, are the one shining example where they really make an effort to have policies that, for example, 6 months of maternity leave and 6 months of paternity leave. And the father cannot say, I give up my leave, give it to my partner. He has to, take it or take a pay cut. So this gives equal opportunities for men and women to not, take a setback in their career. So I think putting in place childcare facilities, for example. So I think very often women do lose some time. And like someone said, Rohini Godbole from India, she's a physicist and real champion for women in science. She said the scientific clock and the biological clock are both ticking at the same time.
They are.
And so for women, that often causes a dilemma.
Yeah. Well, I think it's I did think we have made progress, but I'm worried that along with other areas in which we've made progress in pushing people who haven't been represented in leadership, that there could be a step back. So I really want to turn to climate, because I know that since you've been back in India, you have really, I follow you on Twitter. I still call it Twitter, I just refuse to call it X. But I know that you've been doing a lot of work and around both health issues and particularly women's health issues and women's empowerment. And so I have lots to ask you about this. Let me give you two questions, because I know that somebody's going to come and say, time's up. So first of all, I'd just love to hear more about what you envision that new project to look like. I'm trying to work in climate and health. And I work within a community of people who aren't all in health. And they keep asking me, so what's the big picture? What's the major research question around climate and health? And I have to sort of say, I don't know what the big research question is. It's a lot of what's written in climate and health is advocacy. So it's just kind of making the point. And I tend to see the whole area as diverse as medicine itself, that every aspect of medicine is affected by climate. And so it's extremely hard to articulate a single sort of vision of, okay, here's the framework for climate and health. And I wonder if that's come up in your world and how you think about that.
Absolutely, I agree that it affects almost everything. So I'm looking at it from quite a practical perspective, and from my travels and going to villages in India, I think the food system for me is going to be a big priority, because already, like I said, 3/4 of the world cannot afford a nutritious diet even today. And things are only going to get worse with climate change, because projected yields are going to go down. The nutritive content of crops is going down because of poor soil health and overexploitation of water, soil, etc. So I think agriculture needs to adapt to climate change very quickly indeed, because there are already parts of the world which are becoming desertified, and people can't even grow anything anymore. So we've got to stop that from happening in other places. Otherwise, in a country like India, where still about 60% of the population, their occupation is farming, it's going to have a very big impact. So both on their livelihood, but also on the nutrition of the population. So I think climate, well, sometimes called climate smart agriculture, but just addressing the different parts of the food value chain and the food system, I think that's a very high priority for me. The other one is like we heard in the earlier session today about heat and just the impact that it has on people, and particularly on women, pregnant women, those women who work outdoors, but also on children. So the impact of air pollution, the impact of heat, and the impact of some of the other, acute climatic disasters like floods and so on, disproportionate impact on women. And so I think just researching that, documenting it, and also finding solutions which have to come, from the policy side. Of course, there's some individual adaptation that one can do, but a lot of it the government will have to support. And so one has to take the data to them, because I think many of these things are still invisible, not well documented.
Do you anticipate in India that these crises, which are growing very, very fast, much faster, I think, than anybody anticipated, that they will lead to major internal migration?
There's already a huge amount of internal migration. Part of it is driven by climate. So we recently did a study looking at the impact of, we mapped the climate vulnerability, and 75% of Indian districts are very vulnerable to climatic hazards, floods, droughts, cyclones, etc. And many of them are also pockets where there's a lot of poverty. So this is, of course, causing a lot of migration. Sometimes the men migrate alone, sometimes the women and the family goes along. So and then they all come to a very unhealthy environment in the cities. So there are all these peri-urban settlements where the basic, facilities are not available. So sometimes they end up even worse in terms of their the environmental hazards to their health than they had in their villages.
Yeah.
So yes, I think migration in India, it's a question of internal migration, but of course we see from Africa that there's a huge amount of climate migrants already.
Can you tell us a little bit about what your NGO is doing?
So the NGO was set up by my father 35 years ago, basically to take science and technology to solve societal problems. And it was to look at it quite holistically, not taking one simple technology. But what did happen in the early days was that technology played a very big role. And at that time, this was pre-mobile phones and pre-internet and all of that. So it was satellite-based technologies, basically giving farmers, small fishermen, basic information on the weather, on what crops they could use, where they could get access to fertilizer, etc., but also on the market prices so that they don't get cheated by middlemen. And for the fishermen in particular, I think the app that was developed called the Fisher Friendly mobile app has really proven to be very, very useful for them. Not only does it tell them about the weather, but also about where they can expect to find more fish. And now we're working with fisher women who often do all of the post-harvest work, which is the drying, the marketing of the fish. And a lot of that, again, is very hard work and involves a lot of stress. So how can we use digitally also empower them so that and form collectives so that they can they have a better income, but also reduce the drudgery in their lives. Yeah. So the tagline really is pro-poor, pro-woman, and pro-nature. So all of our programs have to address livelihood security, food and nutrition security, but also ecological security.
Well, good luck to you with that. It's a huge undertaking, but it's absolutely essential. And I want to open this to the floor because I know that I'm sure many people have questions. Vikram.
Thanks, Soumya, for a fabulous lecture. So one of the things of course. Sorry, thank you, Bettina. Thanks for a fabulous lecture, Soumya. I'm going to take you back to the lessons for the pandemic, and I wanted to ask you. You wear two different hats. Or you worn two different hats as India's leading scientist and as the WHO's chief scientist. How do you reconcile the difference the massive difference in the WHO's estimates of how India did when it comes to mortality and India's own government's estimates? How do you square this circle?
So what WHO did and others have done, like Prabhat Jha and The Economist was tracking it, was to look at excess deaths. And so the estimate of excess deaths, at the end of 2021 for the whole world was about somewhere in the range of 14 to 18 million excess deaths. And it was presumed that a lot of that was due to COVID, but that not everyone who died, of course, died of COVID. They died of so many other things, and maybe they didn't have access to healthcare. For TB, we know the TB mortality for the first time went up in those years. They died of heart attacks, cancer, and so on. So governments were counting COVID deaths based on, did you have a COVID test, or at least were you clinically diagnosed and then you ended up dying. So there's several problems here. One is that even normally in a place like India, only people who die in the hospital actually get counted, and there's any kind of a cause of death written down. This is true of many other countries. So people who die at home may or may not get a death certificate, but even if they do, there's no cause of death written. So the estimation of deaths itself is not accurate and is not complete. And certainly the cause of death is certainly only about 20% of the deaths have that. It varies again from state to state. And the excess mortality can only be determined if you have a good system where you're getting real-time data on the deaths, and that's being compiled and that's being put out. So in a lot of high-income countries, that was true. Like in the UK, the Office of National Statistics every 2 weeks or so was updating the overall mortality. And even in South Africa, one could see that you could see the curves, and the curve of COVID deaths was always much less than the overall death. So I think the first thing to differentiate is that the WHO estimate was for excess mortality in the range of about 4.5 million or so deaths that occurred up to, I think, end of 2022, whereas the Indian official death count and the WHO official death count due to COVID is also much, much lower than what they actually estimated was a true death count. And as I mentioned earlier, many parts of the world didn't even have access to diagnostics. So I think that there's a basic misunderstanding between excess mortality and the COVID deaths. And unless that there is the survey, the SRS that's conducted, and the census will give us a better idea, or will give us a definitive, I think, idea of how many deaths there actually were. Otherwise, it's all estimates based on models, and you can always argue, with models. But the fact is that there were several different models that all showed those excess deaths to be in that higher range. So it's probably likely that it was.
Hi, Dr. Swaminathan. That was wonderful. Thank you. I have a question. You talked a lot about the importance of capacity building and particularly in testing and diagnostics. How, from your vantage point, what are countries like India doing given the emerging epidemic of AMR, antimicrobial resistance, particularly in rural last mile communities?
Yeah, so I'm glad you mentioned diagnostics, because I think that was an area where we saw a lot of innovation happening, and we went from the PCR tests that were being done in very highly specialized labs to having the point of care rapid tests that anyone could do in the morning, and many Indian companies were able to manufacture those and get them out. So on AMR, there's a lot of work that's going on. One is, of course, in the area of diagnostics. There's also things like wastewater surveillance that was used for COVID, that people are now trying to see if it would be useful, could be used for AMR. Hospitals are reporting more data, but still we need much more data on community levels of antimicrobial resistance. And again, there's very little investment going into new antibiotics. Because if you look at most of the big pharma companies have all stopped their programs on antibiotics because it's not going to be as remunerative as investing in, in an anti-obesity drug or even in an anti-cancer drug, because any new antibiotic that's developed will have to be used very carefully. And so there's never going to be a very big market. So there's no incentive for the big companies. So again, it's a big gap. It's a market failure, if you will, which needs to be, there needs to be a strategy to address that market failure. There have been some models of, pull and push incentives and things, but there aren't enough. And I know of several biotechs in India that tried to come up with new molecules, but there just wasn't the funding available to take them through clinical trials. So again, it's one of those, I think, topics that needs a global, like TB, like antimicrobial resistance, where I don't think a single country can solve the problem. It has to be a global effort.
I'm going to take a second to just take my prerogative as whatever I am, the moderator, to ask you a question about that. So, is there an alternative to this profit-driven pharma model that would work? Are there who could make drugs in response to need rather than to expected profits?
So there's a simple solution to this, and that is that you have conditionalities attached to any IP that comes out of government or philanthropic funding. So, for example, I mentioned the NIH spends about $40 billion a year, right? So a lot of the research that's driving innovation in this country is coming from taxpayer money. But there isn't any conditionality that's once the IP bill is transferred to a company, basically they can do whatever they like, sell it at any price, and so on. So I think one solution is that for every government and every philanthropic organization that's funding R&D to say, these are the equitable access kind of terms and conditions. The other one is this sort of pooled, I mentioned the mRNA tech transfer program that's, again, a globally coordinated mechanism, that could help to develop new products and share the technology on very reasonable terms and conditions. So there are solutions, but I think till governments, especially of high-income countries, decide that that's the way they want to go, it will be very difficult to change because they want to support the companies in their countries, and the companies are driven by profits to shareholders. So the other thing that Mariana Mazzucato talks about is that we have to move away from shareholder profits and also educate the shareholders, saying that, it's as far as at least health products are concerned, it shouldn't be about profits, shareholder profits. It should really be about public. You can still have some reasonable profits, but what we see today is really, I think, greed rather than need.
Thank you. So my question is, in Taiwan, they had a very effective COVID response, and the VP at the time is going to be the current president or the incoming president. He's a physician. So I'm curious to hear what your thoughts are on the role of physicians, who are medical practitioners, entering public office, right, either in the U.S. or just overseas, to enact, better responses to health, and also whether it's epidemics or just public health. So I just love to hear what your thoughts are on that.
No, I'm sure that it'll, if you have that background, then hopefully you're going to be much more invested in investing in health. And I think even when you look at ministers of health coming, from a health background or being medical doctors, I think they do understand, and but it's not always the case, again. So I don't know if I can generalize. There's been a study of medical doctors, but the few examples I do know, like President Michelle Bachelet of Chile is a great example of somebody. She's a pediatrician, and she invested so much in early childhood education, nutrition, and health, So yes, I suppose if you have that and you're also a progressive person, you can have a huge impact in your country.
So Soumya, you did mention, uh, that it was impressive how India handled the vaccine logistics with the CoWIN portal. I was just wondering what you see in further use of CoWIN for, health services, and is it an infrastructure that actually can add more value to the entire sort of rollout of public health?
Yes, I'm sure it can. In fact, I think the government is already now using CoWIN as UWIN, right? So for the universal vaccination program, and hopefully as we expand our immunization coverage to across all age groups, we've been focusing on childhood immunization, but it's clear now that people need vaccines at different stages of life. And so if we get into adolescent vaccination and then during pregnancy, you need your tetanus, and then in older age, again, now we know that you need vaccines. That kind of platform can probably help track somebody's immunization coverage. So I think that digital tool could be used and will be used. I think certainly in India. In fact, one of the things that we were talking to Indian government about at that time was to give that as we had something called the CTAP, the COVID Technology Access Pool. So it was the president of Costa Rica who came to the DG of WHO and said, again, quite early, May of 2020, said, let's create a COVID Technology Access Pool so that countries that want to donate technologies can do that to the WHO, and then the WHO can decide how to. So we got one technology at the end of 3 years, and it was anyway a technology nobody wanted. So
Yeah.
the serological test or something. So there were mechanisms for people to share. So I remember talking to the Indian government and saying, why don't you give CoWIN? It's a perfect technology to share with the rest of the world. Everybody doesn't have to reinvent. So anyway, the open standards were created for the vaccination certificates. So I think that's, again, in the digital, and you're an expert more than I am, but the open standards allowing people to really make use of that and sort of reinventing the wheel is the way to go.
We have time for a couple more questions. I've got one person right here, and maybe one back here.
Hello, it's so wonderful to listen to you. And I met your father 45 years ago at University of Delhi, and that was my privilege, and it's a great privilege to see you here. My question is about the prevalence of long COVID in India. Is there data on that, and is it being tracked?
Yeah, it's a good question, but I haven't seen any, a lot of publications coming out of India on long COVID. Unfortunately, there is an ICMR study, a cohort that's being followed of a couple of hundred people, and they have found that there's an excess mortality, that there are more people dying in that cohort than you would expect, age and sex matched, especially of cardiovascular events. But that's not the same as long COVID. So there is, I'm sure, because why should it not be in India everywhere else? But there isn't a lot of data that's come out on that. At least I'm not aware.
And we have one more question over here.
Hey, Dr. Swaminathan. I'm sure appreciated all your reflections on the pandemic. I appreciated you walking through the vaccine development all the way to the kind of politicization of the vaccine deployment as well. So I work a lot on youth mental health, and I think we've seen how much COVID has impacted youth mental health specifically. So I'd love to piggyback on your reflections and hear any reflections you have around the kind of impact of mental health from COVID, if that's something that you've thought about.
Well, we have a lot of experts in this room on mental health, so I'm not sure Yes, but you're right. I mean, I think it did have a huge impact on mental health, particularly of young people. And I think the surveys that are being done are showing that the mental health of young people is probably at the lowest at this point than it's ever been in the past, right? So young people are generally the most optimistic and have the best scores. So I think it's the two extremes, the young people, the 18 to 25, and then if you're older than 70, 75, you have a good mental status. But that's got changed. So that's very worrying to see that that has happened. And I think that's impact of COVID, but also of a lot of other things that are going on, including, I think, climate change and psychiatrists that I know in Chennai tell me that they're seeing a lot of adolescent stress because of what they read about climate change all the time, and they worry, about their future. So there are many things I think that they're worrying about. So that is a challenge, but also another big challenge I think for young people was the fact that they missed out on schooling, particularly in many countries where schools were closed for a very long time, and not everyone had access to online education or quality online education. So there's been a big setback in the educational attainment as well. And many children are still struggling to catch up from that. So that could also be adding to this problem.
Thank you both. I should say thank you, doctors, very much, both of you. That was very enlightening, very powerful. It reminds me actually that there's so much in the future to put into practice from what we've learned. Thank you, and please allow me to give you a small token of our appreciation. The chocolate in here is dark chocolate. I'm going to call up Tarun to maybe just close for us. But before I do that, I just wanted to take a minute and just acknowledge our extraordinary staff that has made all of this possible. So I see Mirella there, Carlin is somewhere, Salman is up here, Bettina is taking a picture of me. She has the hardest job because she has to make me a little bit good looking, and it's a large task. People who are not here, I think Thomas is upstairs, Sneha is, whom am I? Ava is here somewhere also. Am I leaving anyone out in this moment? Anyway, it's a small staff. We do a lot. And before Tarun closes, I want to personally thank every member of the team, to thank all of you for coming. And I also want to say, you've heard over the last 2 days a very wide range of activity, and please, this is an invitation to all of you. Join us in planning for the future. That's what we do here. Tarun Khanna, our faculty director.
I'll just close from here because at this point, everybody is at least speaking for myself, intellectually stimulated and physically maybe a bit tired. So I'd recommend we enjoy the sunshine outside, assuming there is some. I haven't been outside, but just to say this is a collective enterprise completely. The team deserves more, 100% of the credit. Really grateful for all of you for coming from disparate locations. Grateful to Soumya for doing this heroic 24-hour flight and back again. You match me in insanity. And to Megan for moderating, to Bharat and Vikram and others, and all the previous speakers and panelists. Thank you all, and we'll see you around. Take care.